All right, so we are going to try this out. This is our first flipped classroom lesson. This is Miss Welsh. This is Chapter 8, Part B, Notes on Joints in Our Body. Let's try this. Going to our next slide. Is this going to work? Nope. There we go. Okay, we have 6 types of classifications of synovial joints in our body. These are plane joints, hinge joints, pivots, condyloids, saddles, and ball and socket joints. These are based on the shape of the articular surfaces, so projections coming out from the bone, the surfaces that are articulating from the end of the bone. We're going to talk about each one individually, starting with plane joints. These are non-axial joints. They have flat articular surfaces, and they undergo short gliding movements. So check out this picture. We see in our carpals, an intercarpal joint within our wrist, we have plane joints. So these are just bones that are gliding past one another. Next, we have hinge joints. An example of a hinge joint might be in our elbow. Motion along a single plane only. It's a uniaxial joint. And it undergoes flexion and extension only. So remember when we flexed our elbow joint and extended our elbow joint. Here's a picture of our elbow, our humerus and our ulna meeting to form this hinge joint. Notice here you can see the picture of the hinge. This is the picture of the ulna and the humerus. Then we have pivot joints. Pivot joints are at the rounded end of one bone when it conforms to a sleeve or ring on the other bone, and it's uniaxial movement as well, movement along only one plane. So here we have a pivot joint at our radius and our ulnus. We see our ulna again attached to our radius. This is a pivot joint. It allows it to pivot around, like when we would supinate or pronate our wrist. Remember those terms from our last lecture. Okay, next we have a condyloid joint, also known as an ellipsoidal joint, ellipsoidal. It's a biaxial joint. Both articular surfaces are oval, and it permits all angular movements. So check out this picture. A condyloid joint, also known as ellipsoidal. Okay, and this would be an example in our metacarpals. Metacarpals connecting to our phalanges. Next we have saddle joints. Saddle joints are also biaxial. They allow for greater freedom of movement than condyloid joints, and each articular surface has both a concave and a convex area. So look at this picture. Great example is in our thumb. Okay, so it's the metacarpal and carpal of our thumb. This is a saddle joint. See this picture? It's saddle-like shape of the two bones meeting together. Next we have ball and socket joints, probably what you're all most familiar with. These are multi-axial joints, and then they're most freely moving synovial joints that we will talk about. So perfect example, like we've mentioned in class as well, is our shoulder joint. We see the head of the humerus meeting with the clavicle and the scapula, and we see this picture showing the ball and socket shape. An example of one of the joints in our body would be the knee joint. This is the largest, most complex joint in our body. It's actually 3 joints surrounded by a single joint cavity. So remember that synovial joints are distinguished by having a joint cavity. This is actually 3 joints within one. So we have the femoropatellar joint. Think about what that might join, our femur and our patella. This is a plane joint. It allows gliding motion during knee flexion, flexing our knee. We have the lateral and mediotibio-femoral joints, attaching the tibia to the femur. Between the femoral condyles, which are, remember, those projections forming joints, and the C-shaped lateral and medial menisci. These are meniscus or menisci. These are cartilage in our knee joint. You'll see them in the pictures coming up. This joint allows for flexion, extension, and some rotation when the knee is partially flexed. So when we're talking about all these joints, I recommend you stand up and try these flexion, extension, rotations that they're talking about so you can become more familiar with them. Do Welsh Pilates at home. Here's a picture of our knee joint. We see the head of the femur. We see the tibia here. We see our meniscus, those cartilage tissue they were talking about. We see our patella, the tendon connecting to our quadriceps of our thigh. We see the patellar ligament connecting to the patella. We remember these bursa, those bursa sacs that contain synovial fluid that prevent against friction. Okay, and we see a bunch of different ligaments connecting the bones together, allowing support and stability of this joint. Here's a view, a superior view of our tibia. So superior meaning above view of our tibia. This is showing the meniscus, or menisci for plural. Here they are. The knee joint has at least 12 associated bursa. So those sacs that we were talking about, there's 12 of them in the knee joint. The capsule itself is reinforced by muscle tendons, those muscle tendons that we pointed out in the previous picture. The joint capsule is thin and absent anteriorly, so absent in the front, the capsule. And anteriorly, again, the quadricep tendons gives rise to the lateral and medial patellar retinacula and the patellar ligament. So here we see that picture of those tendons. So remember, a tendon connects a muscle to a bone. Here we have the patella, the tibia, our fibula. Behind is our femur. And all of these tendons of our different quadricep muscles connecting to these bones in our knee. This is an anterior view of the knee, as we can see from the patella. There are capsular and extracapsular ligaments. Remember, we talked about those were two of our 3 different types of ligaments that stabilize a synovial joint, and they help prevent hyperextension. So remember that hyperextension is going past that degree of normal extension of the elbow. The intracapsular ligament, these are the anterior and posterior cruciate ligaments, or our ACL and PCL. You've probably all known someone in your life who has torn their ACL. It's a very common knee injury. This prevents anterior and posterior displacement, so moving the knee forward and backward irregularly, and they reside outside of the synovial cavity, so outside the joint itself. Here we see a posterior view of the joint capsule in the knee, including the ligament. So this is a posterior view, back of the knee. Here we see an anterior view of the flexed knee. The patella is like cut and pulled forward so that we can see inside behind the patella. Here we have a cool picture with a hockey puck hitting this person's knee. Keep in mind this is the lateral side of the knee, so outside of the knee, and this is the medial side of the knee. So the other leg would be on this side of the body. We see the tibial collateral ligament torn, the medial meniscus torn, and the anterior cruciate ligament torn from this injury. This movement of the joint at an angle it's not supposed to be moving at, this way towards the medial line of the body. Okay, moving on from our knee to our shoulder, also called our glenohumeral joint. This is another example. This is an example of a ball and socket joint. The head of the humerus and the glenoid fossa of the scapula. So the scapula is our shoulder blade. The glenoid fossa is the spot in which the head of the humerus fits in to form that shoulder joint. Stability is sacrificed in ball and socket joints for greater range of movement. So move your shoulder around. See how much you can move your shoulder around. This gives us a lot of range of motion. However, stability of the joint is often sacrificed because of that. We come back to this picture that we've seen before. We have the tendon of our biceps muscle right here, covered by this tendon sheath, which is an elongated bursa. We have another bursa here. We have the acromion head of the scapula, the shoulder blade. Here we have the head of the humerus, and we have the synovial cavity. The reinforcing ligaments of this shoulder joint are the coracohumeral ligament, which helps support the weight of the upper limb, and then there are 3 glenohumeral ligaments, which are somewhat weak anterior reinforcements, so anterior being in the front. Hope you knew that. The shoulder joint also has reinforcing muscle tendons, similarly to the knee. The tendon of the long head of the bicep, so again, attaching to the humerus head. secures to the humerus to the glenohumeral cavity, so connecting. That is the tendon that I tore in my injury I've told you all about. We have 4 rotator cuff tendons that encircle your shoulder joint, your subscapularis, supraspinatus, infraspinatus, and your teres minor. Here we see those in this picture. We have our acromion head of our scapula. This is our scapula, remember you saw in our bone lab. Here's the humerus head, and here it shows all of these ligaments that provide support and stability in the joint. And we see our bursa, again, our tendon sheath wrapped around that tendon. These are protecting us against friction when all of this is moving past one another, so that it's not rubbing against each other, degrading it down, wearing it down. Okay, here we have inside the glenoid labrum. This is actually the structure that I was talking about that I tore. So the labrum is inside the joint. This is like if the humerus was removed from the joint. This is the labrum that protects that inside of the joint. The humerus is removed. Note that the humerus would be coming out here. Moving on from our shoulder to our elbow, we have our radius and our ulna. They articulate with the humerus. The hinge joint is formed mainly by the trochlear notch of the ulna and the trochlea of the humerus. The trochlear notch of the ulna is what you saw in that bone lab. It looked like a hook-like structure. It's going to hook on to the trochlea of the humerus, forming that hinge joint. This joint allows for flexion and extension only. For those of you listening, Nala is sitting right next to me as I record this lecture, and she's going crazy running around my house right now. It's quite funny. I'm trying not to laugh as she runs past me and jumps up onto my couch. All right, moving on. Here's this picture. We see our humerus, right? We see the articular end, the trochlear notch of our ulna. This is our elbow joint. We see our muscles, the tendons connecting to our bones. We see bursa, protecting, again, against friction. The synovial cavity of the joint, forming a hinge joint. The elbow joint has the annular ligament, which surrounds the head of the radius. There are 2 capsular ligaments that restrict side-to-side movement. The ulnar collateral ligament and the radial collateral ligament. Here we have another picture, the humerus head, the radius, the ulna, and then all of these ligaments connecting the joints together. Notice these bone projections. They're sites for ligament attachment, right? We learned all about markings on our bone. Markings are points for ligament attachment. They can attach onto this bone. The bone's structure relates to its function. Here we have a medial view of the right elbow. So we have our humerus over here, radius, and our ulna, again connected by these tendons. Moving on, our hip joint or our coxal joint. This is another example of ball and socket. The head of the femur articulates with the acetabulum. Remember, that's that structure in the hip we were talking about. It has good range of motion, but it's limited by the deep socket. And the acetabular labrum enhances the depth of the socket. So the labrum, remember, is that tissue inside the ball and socket joint. Like if you were to remove the head of the femur, that's what you would see inside the acetabulum. And this enhances the depth of the socket, allowing it to have a deep socket so that it can fit there in there and be very stable, but limits the range of motion compared to the shoulder. Okay, here we have our femur fitting into our acetabulum. There's the acetabular labrum inside of there. This is our pelvis, our ischium, our pubis, our ilium as we go up. This is a frontal section through the right hip bone. So a frontal section, that plane, we cut a frontal cut. We see the spongy bone, epiphyseal line. I know you all know this. Medullary cavity forming down here. Okay, our hip joint has some reinforcing ligaments. The iliofemoral ligament, the pubofemoral ligament, the ischiofemoral ligament, and the ligamentum teres. The ischium we see here. This is a posterior view of the right hip, so from the back. The greater trochanter, a projection on our bone. Here are those ligaments we just mentioned connecting the femoral head to the pelvis itself. An anterior view from the front. Okay, last type of joint that we're talking about, the Temporomandibular Joint, TMJ. This is our mandibular condyle that articulates with the temporal bone. So where our jaw, our mandible, attaches to the temporal bone, that bone on the side of our skull. It has two types of movement: hinge movement, which allows us to depress and elevate the mandible. Remember that during our Simon Says game. Try depressing and elevating your mandible right now. And then it also allows gliding movement, side-to-side movement. Example would be like grinding your teeth. And it's the most easily dislocated joint in the body, which is very interesting. Here's a picture. We have our mandible attached to our temporal bone. We have our external acoustic meatus. That's our meatus, right? A hole or opening in the bone. That's where our ear fits in. We have different fossa, processes, tubercles. All of these things we remember are bone projections and depressions. And again, we have ligaments attaching the bones together. Here we see the sagittal section through the joint. So a sagittal cut through the joint, dividing into a right and left half. And we see the synovial membranes and the inferior joint cavity, so inside this joint. Okay, moving on to injuries. Injuries of our joints, we have sprains where the ligaments are stretched or torn. Partial tears can slowly repair themselves, but complete ruptures require proper surgical repair. Cartilage tears are due to compression and just sheer stress. Fragments may cause the joint to lock or bind. Fragments of the cartilage tears. Cartilage rarely repairs itself. Why? Because it's lacking blood vessels, we remember. And it's usually repaired through arthroscopic surgery. Again, that's when they go in with just a few incisions with a camera and a razor, whatever they may be using to do the surgery, and it's all minimal invasion. Here's an example of a torn meniscus. We see that tear. Okay, another common type of joint injury, a dislocation or a luxation is another word. This occurs when a bone is forced out of alignment within the joint. It's usually accompanied by sprains, inflammation, and joint immobilization. So sprains of those different ligaments in the joint because the bone was dislocated. This can be caused by serious falls or playing sports, any of these things. Subluxation is a partial dislocation. So oftentimes when you sublux a joint, partially dislocate it, you're more at risk for dislocating it later if you don't let it heal properly. That's exactly what happened to me with my shoulder injury. I subluxed it once during basketball season, decided I could play 2 weeks later, dislocated it again a month later, and then had shoulder surgery my senior year of high school. Okay, another type of injury. This is inflammatory and degenerative conditions. Bursitis, which is inflammation. Itis means inflammation of the bursa. So those fluid-filled sacs in our joints. This is usually caused by a blow or a hit, friction in the joint, too much friction, overuse. It's treated with rest and ice and often anti-inflammatory drugs. Tendinitis, inflammation of the tendon sheaths. Tendon sheaths, remember, are those elongated bursa that surround our tendons. This is typically caused by overuse. I'm sure a lot of you have experienced tendinitis or know someone with tendinitis. The symptoms and treatment are similar to bursitis as well. Arthritis, there's greater than 100 different types of inflammatory or degenerative diseases that damage joints, and arthritis is the most widespread crippling disease in the United States. Symptoms include pain, stiffness, swelling of the joint. There are acute forms of arthritis that are caused by bacteria and treated with antibiotics, but the chronic forms, which are osteoarthritis, rheumatoid arthritis, and gouty arthritis, are what we're going to talk about. So osteoarthritis, or OA, is a common irreversible degenerative wear and tear arthritis. 85% of all Americans develop osteoarthritis, and it's more common in women than in men. And it's most likely related to that normal aging process like we've been talking about, that unfortunate wear and tear as you age, as you advance in your age like me. Okay, OA, there's more cartilage destroyed than it's replaced, and it's badly aligned. The joints are overworked. All of this, again, great contributor to that is aging. So what happens is the exposed bone ends thicken, they enlarge, bone spurs can form, and this restricts movement in the joint. Treatment includes moderate activity, mild pain relievers, capsaicin creams, rubbing on top of the site, and glucosamine and chondroitin sulfate. These are all drugs that can help with the pain, inflammation in the area. Rheumatoid arthritis is a chronic inflammatory autoimmune disease. The cause is actually unknown, and it usually arises between the ages of 40 and 50. Can occur at any age. This is just more common as we get older. Again, it affects 3 times as many women as men. So actually, my second grade teacher, I remember, had rheumatoid arthritis. Signs and symptoms include joint pain and swelling. Usually it's bilateral. Anemia, osteoporosis, muscle weakness, and cardiovascular problems. Rheumatoid arthritis begins with synovitis, and it affects the joint. The inflammatory blood cells migrate to the joint, which release inflammatory chemicals. The inflamed synovial membrane thickens into what's called a pannus, and the pannus erodes cartilage, scar tissue forms, the articulating bones connect. All this is wear and tear of the joint. Again, similar to OA. Here's a picture of rheumatoid arthritis. We see the bones out of alignment in the joint, often at a curved shape. And then treatment of rheumatoid arthritis is conservative therapy, which would be aspirin, long-term use of antibiotics, physical therapy, trying to get those joints back in motion, progressive treatment, anti-inflammatory drugs or immunosuppressants, and then there's new biological response modifier drugs to neutralize those inflammatory chemicals, so to try and reduce inflammation in the area. That concludes our lecture for today. I'm going to have you answer a few questions to tell me that you watched this lecture. So on a piece of paper, on a separate sheet of paper, I'd like you to answer the following.